Okay. Hello, everybody. Thanks for coming to another session. Today we have Dr. Davies from the University of Minnesota, Department of Infectious Disease. So I'm going to let him introduce himself, and then you guys can either put your questions in the chat or do the raise hand feature, and you could ask a question yourself. Either way you guys want to do it, and I'll pass it over to him.
Okay, thank you very much. So hello, everyone. I cannot see any faces almost, but I'm assuming you're all there. So yeah, my name is Jose Debes, and I'm an associate professor at the University of Minnesota. I'm a little bit of a mix. So I'm in the Department of Infectious Diseases, but I'm a gastroenterologist. So I specialize in diseases of the liver and the stomach. I also do about 75% of my time as research and 25% of my time as clinical work. And the great majority of my research is about half of that time. It's spent in global research. So I spend most of my time in Africa, South America, and Europe. So I only spend about half of the year, a bit less of half the year in the US. So a lot of the stuff that I will tell you if you ask me about my daily academic life is a little bit different than I would say the average person in that regard. But anyway, I'll be happy to take any questions or talk about anything you guys want me to talk about.
The first question to kind of get us going, why did you choose the specialty that you chose, and what characteristics do you think would be applicable to people who are interested in that specialty?
Okay, that's a good question. So the specialty that I chose, again, it's not infectious disease, it's gastroenterology. And within gastroenterology, I chose hepatology, which is the study of liver disease. I personally chose it because it encompasses a lot of things within medicine. So you'll notice that sometimes if you choose something in medicine, you'll end up doing infections or cancers or metabolic diseases. I chose GI and I chose liver disease because you see everything. You see infections with viral hepatitis and parasitic infections. You see autoimmune diseases. You see cancer of the liver. So you can see multiple specialties applied to one specific organ. The other reason I do like gastroenterology is because it's a half procedures, half medical specialty. So a lot of people, when they are in medical school or they finish their training, they are faced with the decision of either doing what we call a medical specialty, where you just sit down and see patients and talk to patients, or a surgical specialty where you actually do stuff, literally speaking. In gastroenterology, you can do both because you do procedures, you do endoscopies, like, endoscopies, colonoscopies. So you can do things with your hand. So you can have an intervention in which within a minute you change somebody's lives. But at the same time, you can do medicine where you can sit down to people, talk to them, and follow them throughout years of their lives. That is why I chose my specialty. And I'm seeing some in the chat. And I think the first question say, what is a day in your life like? So a day in my life is different, but okay. It really depends which part of the world I'm in. So if I'm here, say, working clinically, literally we have to be in the hospital pretty early. So usually around 7:30, we have to be there until probably 4:30 or 5. If we are doing clinics, so sitting down in an outpatient clinic seeing patients, we're usually working, sometimes from 8 to 12 and then having a lunch break. Then you work from, say, 1 to 4 again, and then you go home. If it's in the procedural portion, so basically you're doing endoscopy, you it's a little bit different. You start working at 7:30 and then God help you until 4 p.m. basically. And the reason I say that is because sometimes you're doing a procedure, and that is, even if you have 20 minutes for that procedure, that can take, you found something you did not expect to find, so that takes you 1 hour. So that delays your entire day, basically. So once you do endoscopy, it's the same as surgery. You don't know when you're going to get a break. Now, that's a clinical portion. The beauty of my life, as I said, is I do a lot of research, and that's a completely different day. So if I have a day of research, it's completely different. I get to go to my office, sit down, think, read about papers about the research that I want to do or not, then do a bunch of meetings with people that do research with me, for me, or that I'm trying to do work with. So it's, again, it varies quite a bit in whether I'm the clinical part of life or whether I'm in the research part of life. Some days are half and half, and those are the worst ones because you're doing clinical work and then you have to switch your brain immediately to do research. And that part sometimes can get pretty tricky, I think. But it's fun anyway. Again, that's if I'm here. If I'm in Africa or if I'm in South America, we're not going to even talk about that, although I'll be happy to, but it's a completely different life. Second question says, what was your path like to becoming a specialist? Oof. My path was different. So I am originally from Argentina. So I came to this country after I finished medical school. And I came to Rochester, to Mayo, to do research. And I knew that subspecialties are more competitive. And I knew as a foreign medical graduate, I face even higher competition. So one of the ways I work around that was in research. So for many years, I did research in molecular oncology, so in prostate cancer and liver cancer, to build my CV. And I did enjoy that a lot. And that actually changed my life because I expected to do research for maybe a year, 2 years, 3 years, and then go into medicine. But then when I saw what research meant to me, then I decided to do my combined life of doing research and clinical work for the next few years. But anyway, once I did research, I did apply to internal medicine residency. So it's 3 years. And then after that, I became a hospitalist because I wanted to get better at medicine and general medicine. And then I went into subspecialty, which is gastroenterology. So my path again was a little bit longer than usual. Next question says, what are the typical diseases, pathologies that you see? So because I do research, I subspecialize a lot. So a lot of what I see is hepatitis B, hepatitis C, hepatitis E, so viral hepatitis of the liver. Also, I see a lot of liver cancer. So liver cancer can also, it all usually occurs in people with liver disease. So usually I see the transition when they have viral hepatitis chronically, and then the transition to liver cancer. Those are typical things I see. When I'm doing procedures or endoscopy, then, we can see colon cancer, esophageal cancer. Keep in mind that our interaction, if you might, at the procedural level is more related to the procedure. So for example, as a gastroenterologist, if I do a colonoscopy and I find a colon cancer, I will get biopsies of that and then send it, but I will not take care of the patient with the colon cancer. That will be the specialist in oncology. He's the one who will do that. So that varies a little bit in the diseases that we see. However, the patients that have viral hepatitis, for example, I will see them for the rest of their lives. I will follow them every 6 months or every 12 months. The next question here says, how do you prepare yourself for a surgery? So again, we don't do surgeries, we do endoscopies. It might seem as the same thing, but it's a little bit different. That question has two answers. That's a pre-pandemic answer and a post-pandemic answer. So before the pandemic, we really didn't prepare much. All we had to do was the day before, you would look at the list of cases that you have, and you would take a quick look about each of them, so you know what's coming to you, basically. And then you go there, you put your scrubs, and you just go in. You make sure to have lunch or to have breakfast or something. And I don't just say that, but as I said earlier, when you're in endoscopy, you might spend the whole day without having a break for food. So you want to make sure you eat in the morning. So in case you have to be starting the rest of the day. With the pandemic, that's a little bit different. So when we go in, I make sure I eat, I make sure I drink. We need to wear N95 masks right now and wear all the PPE and everything. And I do make sure to have a path where we use one computer only. We don't jump from computer to computer. And we just go from the endoscopy room to the computer and back to write our reports. The other problem is more the way after the procedure. When we leave the hospital, basically we need to, and you probably have heard this from many providers, but when I leave an endoscopy room, I change to a different set of clothes, and I have a pair of shoes that I only leave in the hospital. I don't bring home, I leave it in the hospital, and then when I come home, I also get rid of that pair of shoes right away, and I throw all my clothes into the laundry right away. I shower right away, and then I'm ready for the rest of my life. So to make sure we don't bring anything, any pathogens or anything from the hospital to home. Again, this is post-pandemic, obviously. How has your practice changed due to COVID, where you heard part of it? Our life due to COVID has changed dramatically, like everybody's life, including your lives. Practice-wise, it changed in many aspects. At the initial part of the pandemic, all of the elective procedures were canceled, so we were only doing emergencies, and that had two problems. One is that we were in emergency mode continuously. Secondly, that we delayed all the elective procedures, so now we're doing elective procedures and we are super busy, more so than usual. On the other hand, the university and a lot of other institutions stopped hiring people because of financial difficulties, and that affected us a lot. For example, I do my research, so I hire people to do research, but because of the financial constraints of the university, we couldn't hire anybody. So all of a sudden, I had less people to work for me in research. It also increased our fears for sure, because we would come home, thinking that we can maybe transmit the virus to a family member and even get it ourselves, I think. On the other hand, so anyway, those are the bad aspects of COVID. I don't think there's a lot of good aspects, but I think it's important to focus on the positivity things. Some of the positive aspects that we get to work a lot from home. So right now in my office at home, which I wouldn't in any other time, but now unless I have to go to my lab at the university, or if I have to go to a hospital, I don't. So that's different. I get to spend more time with my family. The other interesting way that changed my particular life for the future, I hope, is that we started doing telehealth, as you guys know. So we're doing here, we do with patients. So I see a patient, they talk to me from their house and I'm from my house. That actually, I think, will change a lot of my life, because as I said before, I spent half of the year outside of the United States doing research. So when I'm outside of the United States, I don't see patients from the United States. I see patients in Africa, but not here. But now, for example, we're envisioning that if I go to Africa for 3 months, I can connect to the internet once a week and see my patients here from Africa. So that, I think, are some of the positive impacts that the virus can have. How has machines or computers changed your practice? Well, completely and absolutely, for good and for bad. So I cannot think about my practice or my research right now without computers. I fully rely on emails and on writing charts. So we don't write in papers anymore. Even when I'm in Africa, we have a computer in the hospital, so you're always putting your patients in the computer. So on one hand, that made life a lot easier, because I can see a lot more patients and chart real quick, or chart from home. And by chart, I mean, finishing the clinical chart, the interview and everything. So a lot of those things can be done from home when you're done seeing patients. So that's good on one hand, but on the other hand, it's bad because you bring work to home, right? So sometimes we just go to work, we're done, you're back home, home is done. Now you come home and you have the possibility, the endless possibility to continue to work on a weekend, on nights, it doesn't matter. So you had to be very strict with yourself in putting limits to your life. Otherwise, you spend the whole day working, which you can if you want, but you then forget about your family or fun or anything else. So in that regard, it has changed for worse, I would say. But at the same time, can also change it for better because I can, if I want to do something in the morning that is different, I can do that and then use my computer to finish whatever I had to do in the hospital at night, basically. I don't know if that answered that question. Let me know if that was a different question that you guys wanted to phrase. If you could go back, what advice would you give yourself in medical school? Oh, man. Take time. This is very personal. I'm pretty sure that people give you different advice based on what they live. I was lucky enough that I had a pretty good transition. My best advice would be to do as much as you want or as you can throughout your training time. When I was in medical school and when I was in high school, to be honest, we live by the year. So you go from this year to this year to this year, and a year seems like an eternity. And if I thought about doing some other training or maybe a trip somewhere for a year or half a year, that was a no, because no, I need to go into residency, I need to do this, I need to do that. Well, you get to a point in your life when you're not training, and I don't mean to sound boring, but every day of your life will be the same from then until you are 90 years and you die or whatever age. So my advice is when you're in medical school, when you're before medical school, use your time for whatever you want. If you want to do extra training, do it. If you want to take a break and travel, do it. Don't fear that. It doesn't matter if you spend another year or another 2 years or another 3 years to finish your training or whatever you want to finish. Once you're done with all of that, the rest of your life is the same. So make sure you extend that as much as you want, particularly because at that time you're always, even if you're a resident, you're always a trainee or a student. So whatever you do, if you do it wrong, it doesn't matter. Once you get to my level, whatever I do wrong, it does matter. I'm liable for it. So make sure you take all the time that you can to learn whatever you can. Next one. What has been your most memorable patient experience? Oh boy. I don't know if I have the most memorable patient experience. Some of the most memorable ones I had, if I had to be honest, have been in Africa, mainly because sometimes I've seen a patient or two that I know that if I wasn't there, just because I have a specific expertise, that patient wouldn't have lived. So you feel pretty good with yourself because you maybe save a patient. So a few of those happen in Africa, I think. But beyond that, I don't think I have a particularly memorable patient experience. I love my patients, to be honest, here, there, anywhere, and I love talking to them. I can tell you about crazy stories from my patients, and that's a different one, but I think that would take probably an entire hour. So I'll jump to the next question, I think. How difficult was to get into residency in the US with an international medical degree? That's a great question. It's getting more difficult and more difficult. I always say jokingly that I don't think I would get in if I had to apply right now. I didn't feel it was as difficult as I thought it was going to be, but it was a little bit difficult, if you might. One of the things that I didn't understand, for example, was that when I finished my medical school, as I said, I did research because I really liked it. So I spent about 5 years doing research. And I published a lot of papers, including the New England Journal of Medicine, et cetera, et cetera. So when I applied for residency, I thought I was going to be a rock star, that everybody wanted me. And it wasn't that way. I got a few interviews only. And I was shocked why. And then people told me, oh, because you haven't practiced medicine for 5 years, you've been out of medical school for 5 years. So it's extremely difficult for you to now to reintegrate. So what happened is that I ended up going to a community hospital for 1 year in Boston. And then after that, I reapplied as a second year trainee, and I got accepted. And then things became a lot better because I already was in the clinical training program and I have all this background of research. So then things became a lot easier, if I gotta be honest. So I think if you do research and you are good with personal skills, it might be a little bit harder to maybe get a spot at Stanford or at Harvard, but it shouldn't be very difficult to get a good position at a good university for training. I don't think so. But you have to work a little bit extra for sure. What is the speed that I'm talking about? Okay, guys, is that good or is it going too fast? Okay. What do you enjoy the most, research or clinical work? Great question. I enjoy both, but that's a really, really good question. If you have to stop me right now and tell me, you put a gun in my head and you tell me you got to choose one, I would choose clinical work. I love it because you see the change in front of you. You interact with people all the time. You're always reinvigorated by your patients or depressed by your patients, but you're continuously in a human interaction. And I'm a social human, so I like that. However, I cannot explain to you the value of research in here in my life. First of all, because it allows me to do something different and recharge batteries to see my patients. It gives me time to think about medicine, about other things. And I see my colleagues that only do clinical work, and they're almost like machines sometimes. They don't have time to think, they don't have time to do anything, they just go into there. So research allows me to do that. And I also say research, if I see a patient and I fix a patient, I feel good, but I'm fixing that patient. If I make a discovery in the research side that is important, that discovery will help thousands of people that I don't know, people that I will never meet because they haven't even been born yet. So your impact as a researcher is also very, very broad. So I like both. How do you see your specialty changing in the future? Poof. So my specialty again is gastroenterology and hepatology. I think it will change that it legalize. So now if you do general gastroenterology, you do endoscopy. You see patients with pancreas disorders, you see patients with liver disorders, that's what I do. So the specialty is really, really, really broad. The way I see it specializing or changing is to become more subspecialized. So you train to do what we call luminal. So anything that is in the lumen of your body, right? Esophagus, stomach, colon. Or you would train to do pancreas only. Or you would train to do liver disease only. So that's the way I think it could change. And that could be a little bit sad because you lose that combination of procedures and medicine. But I think as we discover new diseases and we discover new medications, I think a lot of specialties will change that way. So before, say, 50 years ago, they were for any particular disease, there were maybe 5 medications. Now there are 25. So things become a lot more complex. So then we tend to become more subspecialized. How long does a usual research case last? I'm not sure I get that question, Justine. So research, if you mean research project, that really varies from the project. So we do, say, some of my projects are 6 months long, 3 months long. Some of the projects are 5 years long. So when I apply for a grant to the NIH, I look at 5 years. So I said I'm going to do all these projects within a 5-year period. But sometimes we have research projects that within 3 or 6 months can be finished, depending what the project is. I'm guessing that's what the question was. What does the research aspect of your work consist of? That's pretty broad because I have it that way. So I do clinical research is one of my options. So we look at review charts on patients, say they have hepatitis B and progress to liver cancer. And we look at which variables that they had in their hepatitis associates with progression to liver cancer, for example. But I also do a lot of basic science work. So, for example, one of the projects I do, we look at biomarkers for prediction of liver cancer. So we draw blood from patients that are at risk of liver cancer, and then we follow them until they get liver cancer, and then we look at specific biomarkers in blood to see which patient was at risk and see if we can predict who will develop liver cancer or not. So it's a lot of basic science and clinical work. I started this year to do a little bit of qualitative research as well. So we interview people with hepatitis B about their lives, basically, and try to identify factors that might make their life easier. So there are many, many aspects of research. Hopefully that answered that question. What is the best way to get involved in clinical research as a pre-med? Write to people. I get emails from students all the time. Sometimes we can include them in research. Sometimes we can't. We always say, and that applies to my level even, when you go to somebody's house for dinner, bring a gift. It's a saying that we have. And that say means the following: if you have something to offer, that will put you a lot higher. So if you, in your pre-med, you did some biostatistics or some statistics, or you learn how to work with RedCap, the database, or you learn how to write, those are features that will be useful for somebody. So if you say, hey, I want to do research, so you approach the person that you think might be good for you, or that's working on whatever you think is good. It's different if you just go and say, hey, I'm a buddy here to help. It's different if you say, hey, I'm here to help, but I have some basic knowledge either on biostats or basic knowledge on writing manuscripts or basic knowledge on using RedCap. So any knowledge that you have will be welcomed. There is a lot of people out there that need a lot of help for research. So clinicians, particularly clinicians that only do clinical work, we all have great ideas, but not enough time to work on them. So people that help working in there, I think is always welcome. When you choose somebody, make sure you choose somebody that produces quite a bit, so that publishes a lot, has a lot of abstracts, so you get something out of it. And don't ever be discouraged by emails. I mean, send emails. If they don't respond, send to somebody else or send them again. Whenever people email me, I respond. And even if I don't have nothing, I say I have nothing, sorry. But if I have something, I tell them. But do not ever stop emailing until you find somebody. You will find somebody that will need help, and then you can get involved in research. What do you love about your specialty? Would you pick it again if you had to choose all over again? What advice would you give your younger self? Yeah, a lot of introspection here. I love about my specialty is that, as I said, that I can talk to patients, I can see patients, and at different stages, and also that sometimes I don't have to. And this is going to sound weird, but I don't have to use my brain sometimes. What do I mean with this? When I'm doing endoscopy, my actively thinking brain is shut off. I'm doing a procedure. I don't have to think about what might happen. I'm just doing something. But then other days I'm seeing patients, I can interact with them and think about what's going on with them. What I love about my specialty also is that, again, I see some patients with cancer, with liver cancer, and that allows for a very powerful interaction between you and the patient because you are going through a very difficult period of their time, of their life. They might die, they might not. So you are part of that, and that's very powerful. That makes you feel very good. But not all my patients are that way, like in oncology, for example, which that's a route in oncology, which is great, but at some point you might get to feel the burden. But in my specialty, I get to do some cancer, but I also see patients with viral hepatitis, so patients I will treat them and then they will be fine. And that's great also because it's short interaction with the patient, et cetera, et cetera. I think if I were to choose it, I would probably choose the same specialty. The other specialty I would probably choose as well is infectious diseases, which is the department I belong to. Great specialty. Infectious diseases, you get a lot of satisfaction because a lot of these infections just cure the patient and the patient goes home and you're happy. The specialties that are more difficult are the ones where you don't get to cure anybody because then over the years can become a burden. You need to have a special person, to support all of that. But I love my specialty, and I think my advice would be to do the same thing I did, if I gotta be honest. What is the relationship between doctors and physicians assistants and nurse practitioners? Well, that's a very interesting question for a variety of reasons for me. So my wife is a PA, is a physician assistant, so obviously I know that pretty close. I think the relationship is super uber close. Um, I have a lot of respect for PAs and NPs. They know a lot, and my wife is not here, so I can say that freely. They know a lot. They subspecialize in one area. So in that regard, sometimes if you go to the PA or NP portion, you lose a bit of that breadth of knowledge, but you really get to know one specific portion of your career. You get to interact a lot with patients, more so than physicians, I think, because the NPs and PAs are all the time with the patients, and I think that's great. In case, I don't know if you're asking about the profession or not, but I've seen it in my wife that the options are endless. She's doing a PhD right now because she's doing research. So as a PA, you can also do research if you want. But anyway, I think the relationship is really, really good. I've seen in some institutions, in older physicians, and nothing against all the physicians, but all the physicians, they sometimes might treat the PA or the NP as not as good as the doctor, somebody they don't trust that much. But I think that is going away. I think in our profession, in my hospital at Hennepin County, that's where I practice HMC, and at the university, I treat my PAs as my own. They ask me questions sometimes, and then when I have questions about a patient, I'm not that I'm not sure about what to do, but I want to get a second opinion. I definitely ask them for sure, and they give me their input. So in that regard, I think it's a pretty collegial relationship. Difficult to balance the desire to take time and the desire to want to become a. Yeah, that's going back to Justin Palmer said. Absolutely. I mean, the balance between taking time and deciding to become a doctor early. And if you're asking me about the advice to go back, is don't become a doctor early. Don't, unless you want to. There's nothing wrong with it. But if you have anything else that you want to do, go for it. Trust me, you won't regret it, I think. Great advice. What was one preconception you had going into medicine that was vastly changed by actually practicing in the field? Brother, that's a good question. So there are two things I would say that were completely different for me. One directly related to medicine, one related to my reality. The one related to medicine was that I did somehow assume that patients will always be thankful to you for what you do. And that's not the case. I would say that depending which specialty you are, that's half and half. A lot of times patients just complain to you and you work your butt off and try to help them and they just complain, are unhappy. That can become pretty frustrating because you have to be very careful because you tend to then disengage from your patients because you don't want them to hurt you directly. And so that was a bit of a preconception. So you tend to appreciate the patients that do appreciate you. And you really energize from them. So if I see 10 patients in a regular day, maybe 5 will be no good, no bad. 2 might complain that they're unhappy, and then 3 will appreciate what you're doing. And you take those 3, not that you treat everybody the same, but you take what they give you and you put that in your heart, and that keeps you going. So it was a bit of a preconception, which I thought everybody would be appreciative, and it's not exactly that way. The other preconception, but that's due to my reality. As I said, I went to medical school in Argentina. And in Argentina, university is free, so a lot of people become a doctor, good doctors, bad doctors. So if I have to be honest, I never expected that a doctor would be necessarily a very respected member of society, meaning no more respected than any other profession. But when I came here and then in Africa, that was different. People respect you a lot for being a doctor. They respect you socially. That's something that is great. It makes you feel really good, and that's something that I actually did not expect because my reality in Argentina was different. How many patients do you usually see per day? That varies a lot. So if I'm doing endoscopy, I see around 14 patients because we had to do 10 to 14 procedures. If I'm doing clinic, I usually see about, we say 12 patients. No, same thing, 12 to 14 patients a day. That would be an average. Some places are crazy. Some places at the university, you are seeing 20 a day. And some other places, you're just seeing 5, 6 a day. But I personally see about 10 to 12 a day. I would say 12, 10 to 14. As a pre-med, how do I participate in a research? So it's a bit of the same thing I mentioned before. You want to reach out to people. I'm not sure if they are I'm not sure if they are there are specific programs, to be honest. There are a lot of programs through the university where you can become an undergraduate research assistant. So I definitely advise you to go into the website of the university and look into that. But I also advise you to reach out to people. When you reach out to people, do a bit of homework. So see who you're reaching out to and why. And again, try to have something that might be of value for that person. I work with high school students, and they're great to work with. I work with pre-med, I work with medical students. Sometimes I have to narrow because if you have too many undergraduate people working for you, you cannot do a lot. And always keep in mind that working in research is a commitment. So if I take a pre-med student or a high school student, for me it's a lot of work because I have to spend a lot of time with that person, teaching them something, reading what they send me. So it's quite a bit of an investment. It pays off if that person stays with you for several months or a year or 2 years working part-time or whatever, because you eventually get something back. But if you go for a very short period of time to do research, unless it's a very determined project or specific project, then people might not take you because it's more time spent on you than what you might give back the research. As a medical student resident, are you trained in how to deal with your mental health and balance your emotions to death with the patient death and breaking the news to the family? Good question. Yes, you are. Absolutely. As a medical student, as a resident, you are trained to deal with death. You get used to it, to be honest. Doesn't mean that you feel it the less. That if no, it's not if you don't feel it or you don't care, but it doesn't become a foreign concept in your body that somebody's dying. It doesn't. So you do get used to it. I'm going to tell you what you don't learn. And that's where right now there's a lot of discussions about this at every level. We had ground rounds about this last week. You don't learn about how to balance your mental health with the demands of the medical practice. So a lot of times in academia or private practice, there are a lot of demands. You got to be there from 7 to 6 p.m. and you get home and you have all these emails and all this work. And people always ask more for you. And medicine is a little bit different. Like in other professions, maybe you can ask for more money, but medicine you usually don't. And that's the part that is a little bit different. Is we are not prepared to deal with the mental health issues that it brings to have to be pulled in so many different directions and always being asked for more. That's something that is important, I think. The other part, the death part, you'll get used to it. And once you start talking to families, you become prepared. What happens for you to know, if I'm going to tell a family that their loved one is going to die, I'm going with my resident and with my student. And then I tell them that, and they are looking at me how I do it. And then me and 20 other physicians whenever that happens. So over time, you kind of learn how to say that a little bit. And then you say it a few times, and then you get used to that. So that part, believe me, is easy. Hello, those in attendance, doctors and infectious international medical physician, who is special gastroenterology. Do you have that right? You got that absolutely right. So I'm a gastroenterology, hepatology, and I do international medicine. I belong to the Department of Infectious Disease because a lot of what I do, which is hepatitis B, C, and E, is part of infectious diseases. And it's also more of a administrative matter, which means the Department of Infectious Disease pays my salary. That's what it means because I bring grants to them. But as a specialty, I specialize in gastroenterology, hepatology, and international health. So you got that right. It's a little bit complicated, don't worry. Even my colleagues don't understand that very often, so you're fine. What would you suggest to a student who likes the idea of research but really doesn't like the writing part and that prevents him to get into research? Man, that's a very good, man, no, woman, it's Tatiana, a very good, very, very good question. What I could say is that if that's you should try to bring something that the researcher can use from you, meaning again by statistics, knowing how to analyze data, knowing how to use REDCap, because one of the things that take the most time is writing. So usually for me, for example, what I do is I tell one of my trainees, okay, write this paper, and they write whatever they can, and then they send it to me, and then I modify it, I work with it, and then I send it back to them, and they go back and forth like that. And when I find students or residents that don't want to write because they don't like it becomes a problem because that's a pretty big burden on me. And I can tell you that's the same for any researcher. So a couple of pieces of advice. If you're planning a career in research, you need to write. Otherwise, you're you're going to be in difficult times. That's pretty simple. You can do research to catapult you to somewhere else. And that's when you need to bring a different expertise, biostats or something different, or wet lab. Maybe you're good at the lab, and that's great. Also, you can do experiments. The final thing I want to say about that, like anything in life, writing is a process that takes time. I don't even speak English as my first language. I speak Spanish. You can hear it in my accent, right? And I'm actually quite good at writing. I have over 85 papers published in the last few years. But I got that with time, with just writing and learning and working with mentors. So even if you're not good at it right now, you can become good at it to the point that you can enjoy it if you become good at it. Is a project. Thank you. Okay. How do you balance your research career and patience? Do you block off certain days during the week to work and others not? How do you maintain patience while doing patience while doing research? Yeah, that's a great question. So how do you combine patience and research? Two things there. How I do it is a bit different because I spend part of the year out of the country. So when I'm out of the country, I don't think about patients. I'm just doing my research and it's great. When I come back here, what I do is there are certain days that I just see patients. And that's how the majority of people does it or do it. You say, okay, Monday and Tuesday I will see patients, and then Wednesday, Thursday, Friday I will do research, and that's basically how you manage. Now they always interconnect. When you're seeing patients, I can guarantee you your research technicians, students are going to be emailing you, being like, hey, how about this, that? And you need to be adaptable. And when you're doing research, your patients or your nurses will call you and be like, hey, this patient had this problem. What can you do about that? Oh, well. So you're always in both angles. But most people, what they do is they do 1 day or 2 days a week just for patients and the rest for research, depending on which period of your career you are. That's once you're trained. During training is a little bit different. During training, you're probably going to be just doing patients all day and then a bit of research on your time off, basically. That's better for learning, I think. Thanks so much. Do you think MD, PhD is good route for research or MD is good enough? They're both good routes. MD, PhD is great. It just gives you a different breadth of research. So depending what you want to do, if you want to do clinical research, you don't need a PhD. You just go for MD, maybe you do an MPH or something. If you want to do translational or laboratory research, you will have two options. You can do MD, PhD, and then you get good at it, or you do MD, But then at some point in life, you have to spend at least a year or two in a lab doing experiments so you understand what's going on. That will happen to you. So if you know ahead of time that you like research and maybe translation and maybe um, lab research, I would recommend that you go in and do your PhD if you have the opportunity. Uh, I I did my MD only, but again, I worked 5 years in the lab, so I'm pretty good at basic science. Uh, because you don't have the PhD, you get a bit of fighting sometimes from the PhD side. I'm actually working on a PhD right now, so I'm hoping to defend it next year. So you can do that anytime you want, by the way. But if you know ahead of time, do both. Otherwise, you can do MD alone and then do research. That should be good enough. You work outside the country. How do you get involved with that? Is that something like Doctors Without Borders? There are endless opportunities to work outside of the country. And by endless, I mean endless. The ones that people know the most are Doctors Without Borders or MSF. Those are actually pretty difficult because they send you for periods of 6 months or 9 months to a location that you cannot choose and you got to do your work. There's a lot of us, particularly in Minnesota, that work abroad. And it's very easy to get involved with that. You just, usually there are connections. So you go to a place and you work there. It's good to go to one specific place over time because then you create kind of like a connection with that place and you know the place and you know the culture of the place and you start working there. So I went as a resident through the University of Minnesota and now I run my own programs of research there. So I hire people there to research and then I see patients when I'm there to try to help a little bit. But I do it on my own basically through the university. But there are endless options to do that. You don't have to go to MSF or anything like that. I'm also interested in international health. What is your role as an international medicine physician? What is your day life when working outside of the US? It's different for sure. It's a lot more intense and relaxed at the same time. So here everything is very focused. So you come here, you have your patient 8, 8:30, 9, 9:30, do. Outside of here is not that way. If you go to Africa, for example, all patients will show up in the morning. So you have more time to see your patients throughout the day. Usually things start at 9, finish at 3. Things were a lot slower. So if you're in a lab, the lab won't be here until the following day. While here, the lab is in 2 hours, you have it back. So in that regard, you have a little bit more time to work and it's a lot more relaxed. The problem is that you have to be prepared because a lot more people will do poorly. So outside the US, there's not that much preventative medications or medicine. So people only go to you when they have a real problem. So you are not able to fix that many people. So then you really have to be strong because from 10 patients that you see, maybe 7 will die. And that requires a bit of getting used to it for sure. That requires a bit extra strength. And having said that, the ones that you help, I find that they're a lot more thankful outside of here, to be honest. They appreciate you, particularly if you're going from here to there. Like they see that, they know that you're coming all the way to a different country because you don't have to, you just do it. And people do appreciate that, I think. Some people will try to take advantage of you, that's for sure, because they think you're rich maybe, and they try to get you to donate money for them or to pay for the kids' school or whatever. That's also pretty common. But again, I think it's a lot of fun. And then once you're done with work, depending where you are, you can do a lot of different things and fun things. So I strongly recommend Global Health. There's the PG. Yeah, lifelong learner, that's for sure. Okay, okay. 4:22. I think we will pass the 45 minutes, right?
Yeah, I think so.
Okay.
Yep, I think that was all the questions. Thank you so much for coming, and you gave really good answers, and I think we all learned a lot. So thank you so much.
No problem. Hopefully that will be helpful, and I'll be happy to answer any questions that are not in there. Okay.
Perfect.
Thank you so much. Thank you.
Okay. You guys take care. Bye-bye.
Bye.
Bye. Thank you so much.
Thank you.
Yeah. Thanks, guys, for coming. See you guys next week for the next meeting. Hopefully, you guys will come.